We have another exciting day planned for you. I'm Ann Boughton, incoming board chair of Mental Health America, and I want to welcome you to the final day of the 2012 National Zorro Mental Health Symposium and Mental Health America Annual Conference. It's really been terrific, hasn't it? I want to thank Mike Brose and everyone at the MHA of Tulsa and Mental Health America, the staff, the volunteers, and the speakers for what's been a great 2 days. And we're not going to miss a beat today. This morning, we're going to look at tools to support true social inclusion and community integration. And we have 3 excellent speakers to address those issues. Just a quick note, at the end of the presentations, we will have some time for questions and answers. So take some notes and be ready for that. Our first speaker today is going to be Dr. Sally Rogers. Dr. Rogers is a professor at the Boston University Center for Psychiatric Rehabilitation, where she has been conducting research in the mental health and disability field for many years. Sally is currently co-principal investigator of a postdoctoral fellowship designed to train mental health researchers. Dr. Rogers has written numerous journal articles and is a reviewer for various scholarly publications in the field. She is also past president of the Loeb Research Award from the she is also past recipient of the Loeb Research Award from the International Association of Psychosocial Rehabilitation Services. Our second speaker today is Dr. Judith Cook, who is a professor of psychiatry at the University of Illinois at Chicago, where she directs the Center on Mental Health Services Research and Policy, home of a federally funded research center on psychiatric disability and co-occurring medical conditions, as well as a number of research grants and program evaluation contracts. Dr. Cook is an internationally recognized authority on mental health services research, especially the study of clinical and rehabilitation outcomes of children and adults receiving community-based care. Her recent work focuses on randomized controlled trials of evidence-based practice treatments for serious mental illness and outcomes of individuals with co-occurring mental illness and chronic medical conditions. Our third and final speaker today is Dr. Mark Salzer. He is a professor and founding chair of the Department of Rehabilitation Services at Temple University in Philadelphia, Pennsylvania. He is also the principal investigator and director of the Temple University Collaborative on Community Inclusion of Individuals with Psychiatric Disabilities, a research and training center funded by the National Institute on Disability and Rehabilitation Research. Dr. Salzer's research focuses on the delivery of effective community mental health and rehabilitation services to individuals with psychiatric disabilities. His work specifically focuses on identifying and eliminating barriers to full community inclusion. I think you're going to enjoy the presentations today. They each know each other. They've never presented together before, as they told me before the session, so I think this is going to be a good presentation for all of us. Dr. Rogers?
Well, the big question is, can you see me? There's no booster stool up here, so I'm hoping you all can and hear me. I just want to thank you all for the very warm welcome. I've never been to Oklahoma before, and I have to say people are incredibly gracious and hospitable, so thank you. It's also interesting that Judith and Mark and I are presenting together. We've never had the opportunity to do that, even though we are funded by the same national funding body, and we do work that is very complementary and intersects in many ways. So it's great to be with them today. The biggest challenge for me was trying to figure out how I could take all of the work that the center does and condense it in a way that might be most useful for you and the work that you do. My information in the presentation that I'm going to make is very much data-driven and information-focused. So what I'm hoping is that you'll be able to combine this information with the incredible advocacy and policy-making work that you're all doing, and be able to move the field forward using this information. So what I'm going to do is try to coordinate my laptop with that. Tell me if I'm missing the mark here. So what I'm going to do in the attempt to try to hone down the information that I had, I decided that some systematic reviews that the center has done would be most useful for you to hear about. They're in the area of supported housing, peer-delivered services, and supported education. And also, if there's a little bit of time, I'm going to talk about some of the initiatives that we're doing in peer-delivered services, some research projects with a group in Arizona called Recovery Innovations. So what are systematic reviews? We were funded by the National Institute on Disability and Rehabilitation Research to conduct 6 systematic reviews, which are basically very careful, thorough, and objective reviews of the literature. We worked with stakeholder groups and advocacy groups to try to define the topics that we would focus on. And we did conduct 6 reviews. The 3 I'm going to talk to you about today are the ones that I mentioned: supported housing, supported education, and peer-delivered services, because those were the topics that the field was telling us was most important to them in their work. So we were kind of pleasantly surprised when we embarked on the supported housing topic to do a review. The first step in the review is that you go out and you comb the literature. You see what's out there. You specify a time period. In this case, we were looking at the time period of 1993 to 2010. We were able to locate 155 studies and articles on supported housing, which came as a pleasant surprise to us, that the data and the information that was out there was so rich. Many of those articles, though, were more policy pieces and think pieces, and we were actually looking for effectiveness information. What can the research tell us to date about the effectiveness of supported housing? And this is particularly important because in some places in the country and other places in the world, they're still using a linear residential approach. And so this question of, does supported housing work and how well does it work, is a really important one to answer, so that we can be armed as we go to our funding bodies and our policymakers to tell them the evidence that's out there for supported housing. So using a very systematic and objective process, we went through these 55 studies and graded the evidence. And what we found overall was robust and high-quality evidence that supported housing interventions of various types can significantly improve residential status. And I have to say, as a researcher, I was really pleasantly surprised at the quality of the research that was there, because it's not true in a lot of the work that we do. The research can be very weak in terms of its quality, and it can be very inconclusive. So this information was quite conclusive. What we found was that housing stability rates of 80% were found, particularly with approaches like Housing First, the approach that Samson Barris and others developed. And where those programs didn't achieve such high retention rates, they seemed to be lacking in terms of consistent intensive case management for a large percentage of the folks that were in their study. So there seemed to be reasons for why these other approaches weren't achieving very high success rates. There were some other really interesting learnings from these 55 studies, things that can help guide programs as they develop their services. Things like, they seem very intuitive and very logical, but yet it's good to have the empirical data to support this. We found that housing subsidies and affordability led to more success in keeping people housed, and that initially the provision of housing services might be more expensive, but there was at least one very good cost-effectiveness study that showed while those initial upfront expenses are there, there's a huge reduction in service use, including the use of emergency rooms, shelters, hospitalization, and police involvement. And that was a very welcome study because it can help make the case that supported housing, while being expensive, has huge payoffs. ACT and services integration led to greater satisfaction, which was a little bit of a surprise, more contact with service providers, reduced symptoms, greater stability, and better housing outcomes overall. We found also that housing outcomes were easier to affect than clinical outcomes, which might not be a surprise because many of the supported housing approaches focus on the housing first and the clinical issues secondarily. However, it was encouraging to note that in some studies, being in housing actually led to an improvement in symptoms, not the other way around. Sometimes people say, you have to have your symptoms at a certain level before you can be housed, but in fact, it seems that it can work the other way as well. And not to be overlooked, practical services, the more mundane things like help with shopping and cooking and laundry were also important to help keep people housed. This is really a kind of a reiteration of what I just mentioned. Some reanalyses of older data suggested that both substance abuse and psychiatric symptoms could be positively affected by supported housing. And this might speak to, oh, I'm sorry. This is where I'm not coordinated. Doesn't seem to be clicking. All right, I'm just going to have to, I don't know why it's not going backwards. There we go. Nope. Yeah. All right, let me keep going here. These results might speak to the need for specificity of interventions. Okay, thank you, Wendy. Targeting the housing and outcomes with certain kinds of interventions and the clinical symptoms and other difficulties with very specific interventions for that. Participants preferred independent housing and expressed more satisfaction with it based on these data that we looked at. And we found some overarching things like rapid entry into housing increases tenure, quality housing is better. But there were also unmet needs of individuals in residential settings, including needs for financial assistance, problems with social isolation. I think Sam Sambaris mentioned that in the presentation we had yesterday about supported housing in rural areas. Issues of isolation, loneliness, and social integration are still really important, and I know my other speakers are going to be talking about that, as well as clinical issues still remaining important. We found also wide discrepancies, as you might expect, in the perception of staff and clients in terms of what they want. Clients want more independence, less supervision. Clinicians want group living and more supervision. Not surprising, but it was there in the data. The one thing that was interesting is that the role of psychiatric diagnosis is equivocal, meaning inconclusive. So if you look at all the studies taken together, you cannot predict by a person's psychiatric diagnosis that they will succeed or they will fail. So it's kind of irrelevant at this point in our understanding. However, there were certain things that were predictive. Previous criminal involvement and a poor housing history. Were two predictive factors. And the role of demographic characteristics was also a bit equivocal. Being female and a little bit older seemed to portend a little bit better outcomes, but certainly nothing highly conclusive. So our conclusions were that from this research and systematic review that supported housing has robust research evidence in terms of both residential stability and cost effectiveness. Probably the best conglomeration of evidence that I've seen on a particular intervention. A consensus on the primary and secondary outcomes in the field would be useful for researchers like me who are trying to look across studies And when we see that residential stability is defined one way by one person and another way by another researcher, it becomes difficult to join this research together. So a consensus on those really critical outcomes for studies going forward would be a wonderful advancement for the field and for research. The other thing that would be very helpful is to have more in-depth descriptions of the housing support interventions, because many times those were very skimpy and it was hard to know exactly what was provided to the individual. Sometimes the financial support was more well elucidated than the actual practical and emotional and support that the individuals were given. The other conclusion that we came to is that, like supported employment, there are certain principles that can be used for supported housing that seem to cut across all of these studies. Rapid entry into housing, providing choice to the extent that that's possible, being flexible with supports, having long-term supports, and integrating services and care as much as possible, all led to better outcomes. Again, flexible supports, and also ones that match the needs that the consumer or client expresses. The other conclusion we came to is that low-demand supported housing approaches that don't have sobriety requirements may be just as effective in their outcomes among consumers with substance abuse problems. So that was a bit of surprise, and I know is a very controversial thing in the field. So let me stop there and look at my time, and I'm going to talk using my New Jersey voice very fast and try to get through as much of this as I can. This other systematic review that I think would be useful for you to know about was a review that we did of the peer support literature. We focused on the period of 1989 to 2009. We located 122 studies, and in the end could only review 61 of them, because again we were looking for what does the literature and the data tell us, the research tell us about the effectiveness of peer support services. And as you can imagine, that's a complex question because peer support services are very varied. We don't have one model being delivered, but yet we were really trying to learn and glean from this research what would be useful to know about peer support. What we found, unfortunately, for the time period that we looked at was that the results were not as conclusive as we'd hoped, with the exception of some newer studies that are actually authored by my co-presenter, Dr. Cook. The earlier literature going up through 2009 was quite inconclusive. And while peer support services absolutely fill a niche that's unique, that can bolster traditional services, the research just hadn't followed suit. And there may be some very good research reasons, methodological reasons for why we're not seeing that effect the way we're seeing in supported housing. And I think we need to address those problems. We know that peer support services are extremely valuable and needed, and they complement services, but what we don't have is evidence that they do anything better than traditional services at this point, with the exception of these newer services that I'll mention. Oops. I'm behind here. We did find some evidence for group-delivered services, things like double trouble, but there was not good evidence, good quality evidence for many of the peer-delivered services. And the review was hampered by a lack of descriptions and a lack of clarity of the peer-delivered services. Even more so in peer support services, the descriptions of what happens when you provide peer support was horribly lacking, and so we were really unable to conclude very much about what was really being delivered. So our conclusion was that we need more research in peer-delivered services to really be able to make the case, like we can with supported housing, that it works. We need more complete descriptions of the who, what, when, and how of peer support services and the people who deliver those services. The other thing that was often lacking was information about the intensity and types of services. So people would just say individuals got peer support without describing for how long or how many times there was an encounter between a peer support provider and a client. So really just a real lack of clarity. And often there was no description of the service context in which the peer support was provided, or something very minimal. So really, in order to move the field forward in peer support services, we really need to figure out a way to describe those peer support interventions beyond the values and philosophy that underlie peer support, which are really critical. We need to know more about what are the mechanisms that make it effective. So the caveat that I mentioned just recently, and actually in 11 and 12, there were 4 articles published on structured peer support interventions, WRAP, Wellness Recovery Action Plan, Bridges, those were both done by Judith Cook, that show effectiveness. A 12-week course done on recovery that was, again, a structured group course done in Europe, and peer support provided in an emergency room that also looks like it's effective in reducing readmissions. There were not a lot of studies looking at peer support delivered in a supportive housing environment. And there are a number of initiatives I know going on now that could be great new studies. Things like peer-delivered ER services, peer-delivered respite services, and peer-delivered residential services that could allow us to gather more evidence about the use of peers in residential settings. I'm going to mention very quickly a couple of studies that we're doing on peer support in Arizona. We really wanted to add to the body of literature about peer support services, and we wanted to conduct a rigorous study with random assignment. Oof, I don't know what we were thinking at that point, but there were so many difficulties in doing this study that I could probably write a book just about it. But we wanted to work with individuals who are not normally targeted for peer support, those who are undergoing a civil commitment, and we wanted to do a qualitative study to understand the active ingredients of peer support. What do people say is valuable to them about peer support and why? We enrolled 150 people in this study over 4 years, but in order to do that, we had to approach 400 individuals to get consent, because people were mostly in the middle of a crisis. They were undergoing civil commitment, and it was extremely difficult to get people interested in the study, as you might imagine. So the experimental group got a recovery coach or individual one-on-one peer provider. The control group was invited to receive any and all peer support services that the agency provided. So some of the challenges we had were keeping track of this very mobile group of individuals who were being discharged from an inpatient unit undergoing civil commitment was extremely difficult. We also found that a good number of people who signed up for the study and were very committed to the idea of getting peer support changed their mind. Their circumstances may have changed or whatever, but they were already enrolled in the study, and yet 1/3 of them never engaged in peer support, and then we lost another probably 25% of individuals. Also, as we were doing this peer support study, the entire mental health system or behavioral health care system in the area that we were doing the study was changing, and that made it extremely challenging to mount the study. So peer support services are hard to study in the real world. It's a growing workforce. It's a relatively new service, so it presents a lot of challenges for research. That doesn't mean we shouldn't do it, but in this study, we did see some positive differences between the people who received peer support and those who didn't, in terms of their attitudes towards recovery, their ability to cope with symptoms, and their focus on attaining goals, recovery goals. They also reported higher quality of life, better well-being, physical and emotional well-being. Not so much in terms of symptoms and functioning, but that's kind of to be expected because that wasn't the focus of the intervention. So we're happy to be able to add to the body of knowledge on peer support. This study goes beyond the structured and manualized interventions like WRAP and Bridges, so we think it's going to be valuable. And we also were able to do a qualitative study by interviewing 28 individuals using structured interviews, really trying to find out what they want from peer support and what they get out of it. And what we found was really very encouraging. Some of the ways in which people describe their peer support relationship were very heartening and very much consistent with what it should be in the literature. They described their relationship as being egalitarian, supportive, inspiring, respectful, empowering, and friendly. So it seemed as though the identification of the peer support provider, again, this may seem very logical and intuitive, but it was nice to have some verification of that from people receiving the services, that the similarity of experiences was the cornerstone of being able to build that relationship, and that having that relationship represented hope and the possibility of recovery. The relationship felt genuine as opposed to some of their professional relationships, and felt very normalizing. And the fact that they knew there was someone there to talk to was also very encouraging. The tangible supports that a peer support provider could help with, like transportation, visits to a social security office, were also highly valued. Just a quick mention, we are now doing another study of vocationally oriented peer support with the same organization, Recovery Innovations of Arizona, who's been very patient with us in trying to get this study going. We heard from the field that vocational peer support was really important, and so we are in the midst of doing this randomized clinical trial in Arizona. We're also wanting to work with them to really better understand what about peer support makes it effective, and to really try to better describe that who, what, when, where, and how of peer support, so we can add that information to the field. There are some emerging efforts in this direction, but they're pretty skimpy right now. I'm going to skip over this. We did a survey of peer employees and asked them about what was useful to them to their own recovery about being a peer support provider, and we were really very encouraged by the results. People saying that helping others has helped them in their own recovery and helped them to feel more confident in very large numbers. So that was very nice to see. Okay, the last thing that I want to talk to you about, and I have just a few minutes to do that, is the third systematic review that we did. And I have to say that by far this was the most difficult one to do because of the state of our understanding of supported education. And I like to say, when I introduce this systematic review on supported education, that every supported employment study that I read almost universally ends with a call for more education for people that we serve, because individuals get stuck in dead-end jobs, low-paying jobs. And yet we really have not been able to move supported education forward from a policy or funding or research point of view. And that was very much reflected in this supported education review. We targeted the period of 1989 to 2009, and I know there's at least one study being done right now that I can't comment upon because it's not finished. So this includes that period of 89 to 2009. We were only able to locate 21 manuscripts, and I say manuscripts because many of these things that we were able to locate were not, you really wouldn't call it research or evaluation. Many of them were just descriptions of programs, and again, since we're looking for effectiveness information, we needed a research or evaluation component to these manuscripts. But we did the same process we did in the other two systematic reviews. We carefully looked at the quality of the research that was being done and the conclusions, and we tried to synthesize those. What we found was that the largest studies, there was one very large study done in the Midwest in Michigan by Carol Mowbray. It examined what we would call more of a segregated group model as opposed to a one-on-one supported education model. So that's not in great use today. So I don't know how useful those findings were, but those findings were not that encouraging. Some of the non-experimental studies that we looked at were promising, but the methodologies were so weak that we couldn't draw any good conclusions. So there were more anecdotal reports of how people did before and after they got enrolled in a vocational or educational program, suggesting that people enjoyed it and made some progress, but nothing that you could really get your hands around and make a conclusive statement from a research point of view. These are a couple of the conclusions that Carol Mowbray came to before she did her study, that there was no high-quality evidence that participation in supported education results in greater educational engagement or enrollment. No high-quality evidence that supported employment rates improve when you participate in a supported education program. Now, I think a lot of that has to do with the fact that the methodologies and the funding and the services are just not there, and therefore we can't study them. So I'm not suggesting by any means that we give up on supported education, but rather that we redouble our efforts to see that supported education gets studied, funded, practiced, developed, etc. So again, in uncontrolled evaluations, but those were studies that didn't have very good evidence, there was some suggestion that employment improved and educational status improved, particularly completing courses. And this is one of the difficulties with supported ed, is you need a long time frame in order to figure out whether people are going to meet their educational goals, and that's a big research challenge. But again, not a lot of good outcomes in terms of self-esteem, goal attainment. So very little good research out there on supported ed. Some studies are underway, and we're hopeful that perhaps those will yield some promising information. Thank you all very much. This contact information is available, I think, on your thumb drive. And here, if you want to look at more of what the center does, some of those systematic reviews are posted online, and my contact information. Please don't hesitate to contact me if you have any questions. Thanks very much.
Forward. Okay. Good morning, everyone. We have a lot of things to set up here. Okay. I'm going to talk today about tools that can be useful in community integration and recovery. And I want to acknowledge the funding that we receive at my center that allows us to do our research and to think and ponder and about approaches to help people recover and conduct research to see whether different approaches are effective. And I want to start by observing the role of risk in recovery and how important it is to understand that while we tend to focus on the rewarding aspects of the recovery process, community integration being one of those aspects, there are also a lot of bumps along the road and ways in which in our work on behalf of and with and advocacy for people in the recovery process, we don't always take account of those risks. And we don't always develop approaches and supports and services for people that take account of those risks. And I think there's nothing specific about this point to people with serious mental health disorders. All of us have an interesting relationship with risk. And there's been a whole psychology of the study of the decision-making, which really, the process of recovery deals a lot with decisions that people are making about how they want to live their life, how they want to integrate whatever symptoms they're experiencing or whatever difficulties they're having, how they want to integrate that with their hopes and their dreams, and their attempt to move forward and set goals for themselves and live the kind of life that they had hoped to have before they encountered mental health difficulties. So there's nothing really unusual about the notion that people with mental health problems would need to be grappling with the risks involved in making decisions, particularly the decisions involved in what I think is a really courageous process. Recovery is a lot more than just going on to live your life as an adult. It's meeting some pretty serious difficulties and dealing with some very negative perceptions that people have about you and learning to grapple with a service system that's very user-unfriendly. And so when people are making decisions about recovery and the kind of life they want to lead, one of the things that tends to come into the equation is this notion of risk aversion. And that just refers to the idea that the tendency that many people have to prefer a certain payoff, even if it's a lesser one, than to go for an uncertain payoff, even if it has the possibility of being far greater. So what am I referring to here? I'm referring to a person who says, you know, I don't really like this group home, but at least the people here understand me, and I know that I have enough money to be able to live here, and I do have some friends here, although I don't like the rules, and I don't like the neighborhood it's in. So I think I'll just stay put rather than try for an apartment where I can live on my own, which is really what I'd always dreamed I'd be doing. Or someone that says, you know, this job is great, they've offered me a promotion, I'd be working full-time, but I don't know if I want to risk my health insurance. Hopefully that won't be the case anymore, but I don't want to risk my disability income. I don't want to be in a position where there's a lot more stress on me as a manager, let's say, because I'm concerned that it might reactivate symptoms or you know, create problems for me. So risk aversion is something that I think we need to think a little bit about when we're thinking about how to advocate for people who are in recovery, when we're building our own recovery path and hopes and dreams, and particularly when we're helping people in a service delivery or peer support way. Kind of related to this is the notion of loss aversion. And when we're talking about loss aversion, some people really have a tendency to strongly prefer avoiding loss more than the preference and the positive aspects of acquiring gains. And studies show that for some people, losses are twice as powerful in a negative sense as gains are in a positive sense. So I just don't want to turn this into a psychology lesson, but I want us to think a little bit about what we're asking people to do when we're helping them recover. I want you to think about your own tendencies toward risk aversion and loss aversion as I talk about some of these tools that can help support people's recovery. You know, recovery involves a lot of transitions, and transitions can be tough. People do need support in order to make the choice to have a memorable life. But in many people's experience, this is all too familiar, okay? Falling through safety net after safety net as you make decisions about you know, getting a better job, moving out into a more independent living situation, deciding to have a girlfriend or a boyfriend. All of those transitions and important decisions that people are making as they're making, putting together their recovery process. So we don't want to see people falling through all of these safety nets. And so one of the things that I want to suggest in my presentation is that there are tools that people can use and that we can help them use. And one of those tools is shared decision making. And the rest of my presentation is going to give you a little bit of information about each of these tools, enough so that you, if you didn't know about them already, you're now familiar with them, and you can follow up and learn a little bit more about them. So I'm not going to delve very deeply into any one tool. Shared decision making is something that I think a lot of people in a clinical relationship think that they're doing, or even a peer relationship, where there's a joint process that's truly shared by two people or a group of people. The so-called client is playing a very active role. The evidence is being considered, right? And I think, obviously I'm a researcher, I love evidence. But in most medical decision-making encounters, there's a lot of exchange about evidence and what tends to work for people and what doesn't work for people, or what works for people under what circumstances. I find that when we're making suggestions about treatments or services or what you might want to do in terms of your recovery, in mental health, we don't discuss a lot of evidence, even though it's out there. And shared decision-making really does involve a consideration of and a discussion of the evidence. So, you know, the research actually shows that people say they want to share decisions, but in most cases, particularly in the mental health field, and particularly when it comes to the recovery process, decision-making isn't truly shared. So the question is, if people say they want to do it, and clinicians say, you know, that's what I'm all about, then why don't people do it? And what can we do to help advance its use? Some key elements of shared decision-making are that the client's views are very, very important in the process. They're not just listened to, but they are really the foundation for the whole decision-making that's going on. They're a lot more important than, for example, what's available to the individual. Okay, many clinicians start with, well, here are your options, so let's talk about them. In shared decision-making, the foundation is what the client wants to do regardless of whether there's currently any existing options out there. Because part of the process is not just starting with what you think is there, but in helping to make it happen. But you can't make it happen until you truly understand what the individual wants to do, what their values are, what they feel is important in their life. Then there's the sharing of the, it says up there, technical information, but it's also the sharing of the best evidence about what may or may not be helpful to the individual, and helping individuals come to have a comfortable relationship between what they prefer and what the evidence indicates might be helpful or might not be so helpful. The thing about shared decision-making, when I talk to providers about shared decision-making, they feel that it's really doesn't allow them to talk about their preferences and how they feel. And that's not true. I mean, shared decision-making is truly shared. The provider does share how they feel. They do share their recommendations, their concerns. The important thing is making sure that those aren't driving the whole process of the decision-making. And the other thing that providers do that I think is really hard for them to do, and that's acknowledging the uncertainty involved in the decision-making. Saying, you know, this is a hard decision you're going to make about moving out of the group home, and no, we don't really know what's going to go on. I'm not going to just rah-rah this and say, I know you can do it, and I'm sure it's going to be great, and I'll do everything I can to make it work. You want to have that attitude, but I think when a person's trying to make the decision, you also want to empathize with the individual and say, this is a tough decision because we don't really know how it will work out. That's the nature of decision-making. That's okay. You don't have to feel 100% about a tough decision in order to make it and then move forward. There's a number of decision support tools that are out there. People are surprised to hear that many of them are free. And I'm going to say a little bit more about the first two, the Ottawa Personal Decision Guide and the Ottawa I Should. They come out of the Ottawa Hospital Research Institute. And the reason I want to just mention them briefly is because A, they're free, and you can get them off the internet. B, there's a training that you can do, a multi-segment training that you can do in using these materials with people. And you don't have to only be in a service provider relationship. You can go and use the Ottawa Personal Decision Guide for your own decision. Like, should I marry that woman, or should I take that job, or you know, what should I do? How should I make this decision? The Ottawa I Should is the use of the same technology that's been developed and is evidence-based on how to share decisions on Facebook. So if you work with people who aren't Luddites, as I am, and are terrified of the whole notion of Facebook, which is usually people in their teens, 20s, 30s, this is an interesting way that they can share decision-making with a wider network of people than just people sitting in an office or people that are in close geographical proximity. There's Common Ground, the shared decision-making tool for clients and their prescribing psychiatrists, that was developed by Pat Deegan. Some of you, I hope, are familiar with that. It focuses a lot on shared decision-making about medication, whether to take it, what kind of medication to take, how to deal with side effects, how to take medication holidays, etc. And then we have a booklet that you can download for free on how to share decision-making. It's really conversation conversation starters with your clinician on a number of difficult decisions that people are facing when they're engaged in the recovery process. But I just want to say a little bit more about this Ottawa instrument, because I think it's kind of interesting. It helps people identify their options, think about the benefits and the risks for each of their options, then think about whether those benefits and risks are really important to them. You know, a risk is a risk, but if it's a risk that you don't care that much about, then you don't need to get hung up about it. There's a lot of benefits to things, but if those benefits aren't personally meaningful for you, then it's not a benefit you need to be considering that much in the decision-making process. It helps people move toward an option that, based on the information they've thought about, has the most benefits and the fewest risks that are important to them. And then depending on what stage of change folks are in, there's some planning for the next steps that can happen. So there's a consideration of what's supporting or impeding the decision, or what's the person willing to try, and how can the provider be of help. I'm showing you this because I like to frustrate people with things in mosquito font. No, I'm showing you this to show you that this is a one-page, one-side form that people work through and fill out together and using this tool. So it's very user-friendly and it's simple. So that's why I'm showing it to you. And here's the top half of it, and I just wanted to use it to illustrate things like how an individual lays out what their decision is. In this case, this person says, I want to go off SSI and make more money and have a better life. They then talk about what's their time frame for making the decision. This person said over the next year. They're asked to say how far along they are in making the decision. This person checked, I'm thinking about options at this point. They then check how certain they feel about the decision. This person's not certain at all. How much knowledge? Do they know what options are available to them? Do they know both the benefits and the risks? This person said no to both of those things. And are they clear about what values are involved in this whole notion of going off of SSI? This person said no to that. Then moving down the page, the person lists the benefits and the risks of different options. So option number one is, I make sure to keep my earnings below SGA, so I don't try to go off of SSI. And then they list a bunch of benefits. I'm guaranteed an SSI check. I know how much money I'll have each month. I'll get my Medicaid. And they list the risks. I feel watched like a prisoner on SSI. It's not enough money to live on is a risk. And I don't like the Medicaid doctor that I have right now. So in this case, the person had a little epiphany. Why am I so worried about staying on Medicaid when I don't even like the doctor that's available to me through Medicaid? Option two is I try earning above SGA for 2 to 3 months, and the person lays out the benefits and risks there. And then option three is I open an IDA, and I'll talk about that in a moment. It's a special savings plan. I go back to school. I'll do a PASS plan. At the bottom of the page, the individual kind of gets into some nitty-gritty things about who's involved in their decision. And in this case, their husband's involved, their mother's involved, and their employer support person, their employment specialist is involved. The person's asked to say, which option does this person prefer? And is this person helping you or pressuring you? So in this case, the person says, well, my husband wants me to stay on SSI. My mother wants whatever I want. And my employment specialist, well, I'm not really sure what he wants. I think, he's neutral. So how can this person help you in your decision? Well, my husband can get off my back. My mother can keep encouraging me. My employment specialist can help give me information. So I don't want to belabor this, but it's an interesting, engaging way to explore with people a decision-making process. And I think if you try using it with someone, a client, a family member, whoever, you'll find that in discussing all of these things together, decision-making does become more truly shared. Evidence is considered. Information is gathered. And here's the page on the web site where you can go through the tutorial and learn how to use it for yourself or use it with another person. So because I think that shared decision-making is so important for everyone, but particularly for people that are loss averse or risk averse. I think that it's an important thing to be thinking about and encouraging the use of, whether it's a formal service, a peer support service, or you're just supporting an individual who's in the recovery process. So Mark Twain put it very well, I think. You want to go out to the end of that limb, even though it's going to bend, because that's where the fruit is growing. And that's what recovery is all about for people. The next tool, you can see I have a little tool icon up there when I'm introducing a new tool, in case you've just woken up and you're not sure where I am. It's a tool of financial literacy. And financial literacy is something that I bet at least 70% of the people in this room, if I said, how comfortable are you with your current level of financial literacy, you would probably say no. We're all bad at financial literacy. It's a shame we don't teach it in our schools. It's a shame somehow we think we acquire it from being an adult in society, and you learn it from your family or whatever. But it's this ability to understand your own financial situation, to manage your personal finances, and to engage in financial planning. And for people with psychiatric disabilities, this is a very foreign concept. So first, let's think about the fact that it's a foreign concept for many of us. Then let's think about the fact that it's doubly foreign for people with psychiatric disabilities because they have so little money to manage. And over time, either they feel or we reinforce in them the feeling that because they have so little money, it's not worth knowing what their financial position is. It's not worth doing a budget. It's not worth trying to save because the idea is if you don't have a lot of money, you can't save money. That's not true. And that's what's so interesting about this whole field of financial planning. This is a quote from a woman in Chicago that we interviewed at my center when we were first exploring this whole area, who said, by the time I pay all my bills, there's hardly anything left, there's no fat to trim, I can't save. And sometimes people feel like this, a very fatalistic way. I may not be here tomorrow, I don't have a whole lot of money, I'm just going to spend it because who knows what's in our future. We developed a financial education course for people with psychiatric disabilities. It's really not that different than a lot of other financial education courses that you can get on the web, except we really took what was out there, we distilled it, we worked with other people in recovery to learn how to adapt it so that it could be used better by people with mental health problems. And they wanted it to be shorter, they wanted it to be funner, they wanted it to be less depressing. They wanted it to involve a lot more peer support and a lot less, you're bad, you spend too much money, you have credit cards that you've run debt up on. They wanted help about those issues, not to feel bad about those issues. So I mention it because it's freely available from our center, and we developed it because of the next tool I'm going to tell you about in a moment, required it. But what we found is that it's really actually, once you get the manual and force yourself to read it and engage in the exercises and learn to teach it to other people, it's really not that difficult to teach to folks. And it's a very good tool for peers to use with each other, but it's also a good tool to introduce in a plain old mental health or psychiatric rehabilitation program to get people thinking a little bit more about their financial futures, understanding what their futures are, and so forth and so on. I don't have enough time to really review it, and so I'm just going to go on and, wow, it's 9:21, huh? And I have 5 minutes left? Yeah? All right. So I just want to talk about or just mention before I go on to my next tool, the idea that people with mental illness are no different than the rest of us. This Pirates, you've seen the TV commercial where the guy didn't check his credit rating, and now instead of, being a doctor, he's stuck at this restaurant. People with psychiatric disabilities are no different than anyone else in the community. They just need some extra help, and they need to be treated as if they do have a financial future and they can save money. I now want to move on to another tool called asset accumulation, and I want to mention this idea that it's not your income that helps you move out of poverty, it's the assets that you have available to yourself that help you move out of poverty. And 1 in 5 Americans doesn't have enough assets, savings, or home equity to be able to survive even at the level of poverty for 3 months if they were to lose their income. And folks with psychiatric disabilities have even less. There's a federal program called Individual Development Accounts where low-income people, which are many of the folks that we're talking about advocating for, providing peer support to, can save money for a first home. I love the federal government, as if poor people would be saving for a vacation condo or whatever, but the feds want you to understand that this is your first home. Small business capitalization if you want to run a micro enterprise, or post-secondary education. But the money must come from a job. The person must be working. So this is a wonderful mechanism for people that are in supported employment programs, because they are making money. The individual has to meet certain kinds of poverty qualifications. A nice thing about this is the savings in an IDA are not counted against an individual's SSI or SSDI check. And that means the individual can save without having financial consequences in terms of their disability income. The person must receive financial education, so we developed our course so that we could explore this whole idea that comes out of the area of poverty, which has many interesting ideas and programs that we need to explore in mental health, because, as we know, part of the problem of folks that have mental health difficulties is not necessarily the mental health difficulties, it's the poverty that they live under and that we're trying to help them address. The nice thing about an IDA is the fact that the person puts in some money, but then it's matched twice. If a person can come up with $20 a month to save, the federal government puts $20 in their savings account, and then a local bank or philanthropic organization or state agency matches with another $20, and the person has now saved $60 for that month. All right? So that's an IDA. Obviously, you have to work with the person to help them be able to save a certain amount of money each month, and you have to help them enroll in an IDA program. At the bottom of this page is a website that you can go to see if there's IDA programs in your state. And I want to share with all of you that there's a mental health affiliate, which I couldn't remember before I came up here, and I'll never remember now, that actually explored using IDAs for people with mental health difficulties. So NAMI groups can do this, MHA affiliates, mental health programs, peer programs. There's a peer program in New Jersey, community support, collaborative support programs of New Jersey that runs an IDA program for its members. So it's an important thing to be thinking about if you care about asset accumulation. Don't know if you're hockey players, but you will definitely miss 100% of the shots that you do not take. Peer support and self-help, I think Sally really covered that well, and I'm out of time, so I think I'm just going to click quickly through these slides and talk about the fact that the emotional support, as well as some of the practical assistance along the lines of IDAs and microloans, are important in peer support because they help people manage the risks that they're taking. And then finally, I just want to say a little bit about self-direction. Sally mentioned the WRAP program, Wellness Recovery Action Plan. Raise your hand if you've heard of WRAP and you know about it. Okay, so I don't have to tell you too much about WRAP. The thing about WRAP that's so important is that you can help people self-direct their own recovery. These are the folks in a WRAP study that we completed recently that showed that helping individuals be able to manage their own mental illness, reduce their psychiatric symptoms, increase their sense of hopefulness, decreased their way of coping by blaming themselves, increased their quality of life, their ability to advocate for themselves, their sense of recovery, and their sense of empowerment. So this notion, and WRAP's now an evidence-based practice, of being able to self-direct not just your services, but how you manage your illness is, I think, an important point in this whole notion of risk-taking and recovery-making. Helen Keller, I think, put it really well. I mean, here was a woman that had an uphill battle in terms of her own recovery. And she points out that really security, though we think we're clinging to it, we think we need it and we like it, it's really a superstition. It's not a natural situation. People as a whole don't really experience security. That really, the notion of taking risks is what it's all about in terms of living life. I think it's also very key to having a good recovery. And I want to thank you today for your time and your attention.
I've got the lavalier mic on, I hope. I'll take that. Yep, thank you. So I've got 3 sons, 17, 15, and 13. And the great thing about having children is there were about 20 years between when I went to concerts, rock concerts, right? And about a year ago, my 17-year-old's into music, into playing guitar. He's got a band, you know, all that kind of stuff. About a year ago, we went to a Foo Fighters concert. And I don't know who knows the Foo Fighters. Dave Grohl is great. You know, I wasn't a big fan, but they've got these thrust stages. They had them a long time ago when I used to go too, but the stage would go out, and they do that to connect with the audience, right? So the people in the cheap seats in back, right? They don't feel left out. You know, it's not just because you got here late. You know, you don't get left out from the presentation. So I'm a big fan of this. So you can call me the rock and roll presenter. I'm not a rock star, but I like to present in this kind of way instead of standing up there on the stage, even though it's going to make this gentleman's work a little tougher as he chases me around. So anyway, it's great to see everybody. It's wonderful to be here in Tulsa. I've been here for a couple of days and seen some wonderful presentations. There's terrific work happening at all of the affiliates, all of your work out there. I went to a great faith-based session. I went to a session on intimate relationships. I went to a couple of different things that are just outstanding. You're all doing wonderful work out there. I'm also thrilled to be here with my colleagues, Sally Rogers and Judith Cook, because as people have mentioned, we haven't worked together in the same kind of, even conferences. We actually don't always go to the same conferences and present together. And this is important to me. We're all funded by the same funder, the National Institute on Disability and Rehabilitation Research. We all have these rehabilitation research and training centers. NIDR, that National Institute, is within the Federal Department of Education. And we all have these centers. And mine is the Baby Center. We've only been around for 9 years. They're a little more established, and they've done wonderful work for a long time. And when we first got funded about 9 years ago, I used to tell people that we were like, you know, we've now moved into the neighborhood with the big mansions. We still have the little shacks, but Judith and Sally and their colleagues at UIC and BU, those are the mansions, and I'm happy to be in the neighborhood with the mansions. Still have the shack, but that's all right. We're working on that. So anyway, it's great to be here. Our center, based at Temple University, is a collaboration with a provider agency, Horizon House, and a mental health affiliate, Mental Health America affiliate, the Mental Health Association of Southeastern Pennsylvania, and the National Mental Health Consumers Self-Help Clearinghouse that Joseph Rogers directs. So we're really proud to be able to partner with them as part of this collaborative. What I'll be talking about today is really following up on some of the tools that Sally presented on systematic reviews in all those different areas, and it's wonderful work that you can go to their website to get, and to follow up on some of the tools that Judith was talking about. Not follow up, but add some of the tools to your toolkits for promoting recovery and community and inclusion. And the tools that I'm going to be talking about are a measurement tool. And I was thrilled in the opening plenary when David Shern and Wayne Lindstrom and Michael Brose were all talking about the importance of evaluation and measurement. We need to document all the wonderful things that I've been hearing about the last couple of days. We need to document those things. Funders like that kind of stuff, right? Policymakers like that kind of stuff. They want data. They like stories too. Stories are important, but they want the data. Okay, and I'd like to show you a tool that you can use to measure community participation of the individuals that you're supporting, that hopefully that's an outcome of all your programs and your initiatives, and you can take that and show people this is what we're doing. We're having an impact on employment. We're having an impact on education. We're having an impact on dating. We're having an impact on people spending time with friends. We're having an impact on people engaged in spiritual and religious communities, okay? So that's a tool that I'll be sharing with you. And the second tool is more of a conceptual tool, okay? It's not an intervention. It's not a new document that you can use in your programs, but it's something that we're coming to believe is very important for understanding recovery and for understanding community inclusion, and that's the environment that people live in. And actually, the environment that all of us live in has an impact on our lives. And this isn't just, usually in mental health, when we think about environment, and especially with housing, we think about, you know, the house. Does it have, you know, nice bathrooms? Are there insects in it? Is it, you know, the local physical environment that the person's in? We're actually talking about neighborhoods and communities and resources and those kinds of things. So I'm going to show you some neat little maps to try to help you think about the importance of environment in people's lives and the importance of our intervening and advocacy to address those environmental factors that do impact the lives of people that, that we support. So that's what I'm all about. And I'm also up here, so I can't see Wendy's little 25-minute thing. So she's going to have to chase me down and say, Mark, it's really time to end. And, but I'm coming to look. I'm in good shape so far. So measuring community participation. Our center is about the, we're looking at the community participation of adults with psychiatric disabilities. And one of the first things we wanted to do is look to see what measures are out there. And there are not a lot of measures out there. There's actually one other measure that we've come across that assesses community participation of people. And we wanted to develop a low-cost measure, something that could be easily usable by people and by providers as an assessment tool, as well as a research tool. So I said low-cost, low-burden community participation measurement tool. The other thing that we needed to do in this particular study as we developed it is we needed to document to people that individuals who experience serious mental health issues can actually do this tool, can actually complete it. There were concerns. We would talk about, and I'll show you the tool in a couple of minutes, or not the actual tool, but some of the questions on this tool is how many days in the last 30 days have you worked for pay? How many days over the last 30 days have you gone to a church, synagogue, or mosque? Okay? And I would talk to providers, and I would talk to funders, and they'd say, oh, no. Our people are too sick. They couldn't possibly do something like that. They couldn't possibly remember what they did over the last 30 days. So we had to go document that. We actually had to do a study to show that people can do a pretty good job remembering what they've done over the last 30 days. Concerns about self-administration. Can people do it by themselves, or do they need a staff person or an interviewer with them? And there's an interest in understanding self-determination in measuring community participation. One of our biggest concerns about the focus on community inclusion is that providers feel like you have to drag people to leisure recreation programs. Like, you know, you should participate. You should do this, right? You should go to this baseball game or bowling or whatever, and you drag people to it, but you don't ask them, is that important to you? Is this something you want to do? So self-determination is really important in developing these kinds of measures. So we developed this measure, and we administered it to 119 people, and I'm going to show you some of the results right now. These are people who have been diagnosed with schizophrenia spectrum disorder or affective disorders. They're randomly assigned to 2 different conditions, interviewer-administered or self-administered, and they completed the measure at 2 points in time. I'm actually not going to focus too much on the reliability. I'm going to focus more on the data, because we don't have good data on what people do in their lives. Okay? Providers have no idea. You ask them, they have no idea what people are doing outside programs. right? No idea how many times, how much people are spending with friends, how many times they're going to church, synagogue, mosque, how many times they're working for pay that they don't know about. And I think it happens more often than providers think, okay? The measure that we're talking about here, the community participation measure, is how many days over the last 30 days did you do the following activity without a program staff person going with you, okay? So this isn't staff-supported participation. Do you do this activity enough, not enough, or too much? And is this activity important to you? Those last two get into self-determination, okay? Those are the things that we're most interested in. I did not put this in here to frustrate you with small font. I actually put this up so when you take your little USB that you got when you came in, you'll be able to actually see it on your own computer at home. I knew you wouldn't be able to see it way back here. I can't even see it. Well, I can see it a little bit, actually. My eyesight has still been pretty good. So what this is these are the 26 different areas of community participation that we're measuring. And over here is the overall mean. How many days over the last 30 days, on average, these 119 people said they did things. So this sample came from Philadelphia. So we've got pretty good public transportation in Philadelphia. People said that they used 14.85 days of participation of public transportation, okay? Not surprising in Philadelphia. Some of the other things people said that they were doing, they were running errands 7 days in the last 30 days, going to a restaurant or coffee shop 4.6 days last 30 days, 12-step group for mental health issues 4.57 days, volunteering 3.72 days, working for pay 3.1 days, go to a church, synagogue, or place of worship 2.4 days, okay? So this gives you a sense of what people, this sample from a lot of different programs at 2 agencies that we were working with, gave you. Providers were, they'd never even thought about this kind of stuff. They never ask what people are doing, and they were very interested in this. We're also using this measure in the Philadelphia day programs, what used to be partial hospital programs. They've been using this to gather data as well. But there are some areas that people aren't doing a lot of. Take a class for leisure life skills, less than 1 day in the last 30 days. Go to a zoo, botanical garden, or museum, 0.62 days, less than 1 day in the last 30 days. Okay, we don't know if that's a lot, is it different from the general population, whatever. What I'm most, I'm going to skip this, and I'm going to skip that. What I'm most interested in is these data right here, okay? Again, we were asking how important is this to you? Is this important to you? Do you want to do this? Yes, no, and if it is important to you, do you do it enough, not enough, or too much, okay? This is the most important thing to me about this measure. One thing we found, so these are all the important, yes, and it's less than they want. It's not enough, okay? Going to a movie, 56% of people said that that was important to them, and 70% of those people said they weren't doing it enough. This is important. I want to go to a movie. I'm not doing it enough, okay? Going to a gym, 71% said that that's important to them. 66% approximately said they weren't doing it enough. Okay, let's do church, synagogue, or place of worship. 78% said that that's important to them. 59% said that they weren't doing it enough. Okay, for me as a researcher, this is pointing out areas where we're not doing a good enough job in our services. I could do a whole other presentation where I could show you evidence saying that all of these things up here are good for people's mental health. Okay? I've got a whole other presentation. You can invite me back or whatever. But these are important things to people's mental health. They're not doing it enough. Okay? These are target areas, not just symptoms. These kinds of things, supporting people in participating in the community in ways that they'd like to participate. I talked to providers about changing their programs, changing their services to really target these kinds of outcomes. These are good programs where we got these data from, and people are not participating enough. Okay. Well, what I'm not going to have. the last thing we did is we actually looked at the importance of community participation as it's related to quality of life and recovery. Our thing is community participation, community inclusion facilitates recovery and well-being and quality of life. These are correlations right here between how many days people participate in the community and their quality of life and recovery scores on one particular measure. And we actually find statistically significant relationships between the two. And we would argue that community participation, people being engaged in ways that they want to be engaged in the world, is important for recovery and quality of life. Kind of a duh kind of thing. But there isn't data out there indicating that. Now you have the data to be able to go out and say community participation is important. That's what we're going to focus on. Okay? So that's one tool that you have, right? If you want to measure, I think you should measure community participation. You can use this tool. You can use whatever tool. I think just do it. It's important. It's a great outcome for your programs, something to really demonstrate worth, and it's what people want to do in their lives. The second thing is talking about the importance of environment in which people live and impacts on their lives. This is really influenced by a change in paradigm that's happening. I don't want you to have to chase me. So 10 minutes, I think I can do this in 10 minutes. So a change in paradigm from the individual model of disability. This is from our center is really influenced by the larger disability community, what people with, who experience physical disabilities, sensory disabilities, developmental disabilities in particular. They've been talking about community integration, community inclusion for decades. Okay, we're kind of babies when it comes to talking about community integration, community inclusion. So I can also stop and see people. They have to look at me, pick up from what they're doing. So individual model of disability is viewing the lack of participation, okay, the lack of functioning, going to work or whatever, as something inherent within the individual. Okay? John has schizophrenia. That's why John can't work. He's disabled. It's something within him. Okay? That's the individual model of disability. That's really what drives a lot of our mental health services. Even some of our rehabilitation programs are really driven by an individual model of disability. We need to fix John. Okay? There's something wrong with him or Jane or Suzanne or whomever, right? There's something wrong. We need to fix the person. Okay? The social model of disability, people in the disability community have been talking about for about 40 years, so it's actually not new. I used to say new, maybe because it was new to me, but it's not so well known in our mental health community. Disability results from a person-environment interaction that reduces opportunities for people to live like everyone else. Okay? A person-environment interaction. Okay? It's not necessarily that John has schizophrenia and has certain ways of behaving and interacting with other people, but it's also how that environment interacts with John, right? So if the environment is not welcoming of John's differences, that's what causes the disability. That's what causes the lack of functioning. If I am interested in going to church, okay, but I might have some unusual behaviors, and that church kind of makes me feel unwelcome, that disability isn't because I interact differently. It's an interaction. Okay? I could change my behavior a little bit, but that church, those church members, that pastor could also change their approach, or the other congregants. The other members of the congregation could change how they welcome that individual to participate in church. So that's the social model of disability. What the social model of disability means, okay, is we intervene in two different ways. One is we intervene by addressing, we can address and provide supports to help people with the impairments, the issues that are associated with the illness or whatever. Okay? So we can do our skills training, we can do our cognitive remediation, we can do all that kind of stuff. Those we call supports. Okay? But we can't stop there because we know the environment, these other things, are also areas that we can affect. That's why advocacy is so important, to change the environment, okay? To address the environment, and that's the other way that we can intervene based on a social model of disability perspective on the experiences that people with mental health issues have. Okay? So I'm going to talk about some of the things that we're starting to look at and identify in terms of environmental barriers, things that impact people's lives. Okay? And our work in this area really started with this map right here. And what I love, thanks for changing that. What I love about being here too is I've got a lot of friends here who are from Philadelphia or the Philadelphia area. So actually Sally, Mary, Evans, and Judith are all from the Philadelphia area. So they recognize what this is. This is Philadelphia County right here. Both sides. The left side is the concentration where people live in Philadelphia County who receive Medicaid reimbursed services as a result of having mental health issues, okay? Or they're receiving Medicaid reimbursed services for mental health issues in their lives. That's on the left-hand side. The right-hand side is a concentration map of people, other people on Medicaid, but not receiving mental health services, okay? And don't have diagnoses like schizophrenia, bipolar disorder, major depression. What we were trying to do here is just see whether or not people are more segregated or ghettoized, it's actually a sociological term, in certain parts of Philadelphia, people with mental health issues versus other poor people, other people who use Medicaid reimbursed services. What we basically found is there's evidence of modest residential segregation. So there is evidence that people with psychiatric disabilities are slightly more segregated from the general Medicaid population in Philadelphia, but it's very small, very modest. Some of my colleagues who actually were authors of this study, you know, kind of not so sure. But the take-home message here is both people, including people with psychiatric disabilities, are living in some of the poorest communities, poorest neighborhoods in Philadelphia. And they're actually neighborhoods that, this is part of my new home. I'm at Temple University now in North Philadelphia. It's actually on the rise, but there are still some issues in the immediate neighborhood. And just like anybody else who lives in a neighborhood that has some issues in that neighborhood, that's going to affect your life. Okay? That's going to make you more concerned. That's going to make you stay at home more often if you fear crime, right? There might be fewer job opportunities. All those kinds of things might be going on. So some of the questions we've been asking are, do people who experience mental health issues have different access to neighborhood amenities? Okay. Supermarkets, pharmacies, banks, post office, department stores, all those kinds of things. This is actually a list. One study that we've done is we actually ask people, what is important for you to live close to? Okay, what do you want to have in your neighborhood? We haven't found any literature on this, right? We're asking people what's important to them. First of all, I don't think that this is too different from the general population, except hospitals, community mental health centers, and mental health providers did stand out as some of the top, I think, top 15 areas that people said that they wanted to live near, okay? And what we did is we actually looked to see whether or not people with serious mental health issues live closer to these places compared to the general population. Do they live closer to them, or are they in an area where there's a higher concentration? There are more of these things. So more supermarkets, more restaurants, more pharmacies, etc. And we actually found in some ways that people who experience mental health issues actually have some advantages in this area in terms of access, which was quite interesting to us. They actually live closer to some of these things. They actually have more concentration. There's some areas where they live a little further away, like department stores, banks, and credit unions. But this is the stuff we're starting to explore right now. Our second question had to do with whether or not people with serious mental illnesses are residing in communities with more what sociologists call social disadvantages, okay, social and physical environments. And these social disadvantages are things like physical structural inadequacy, okay, broken down homes, homes that are vacant, those kinds of things. This is some of the maps that we get to play with in our center. The darker areas mean more physical structural inadequacy. The taller the mountain means heavier concentration of people who experience mental health issues, okay? So in almost all of these areas, The mountains, where more people who experience mental health issues live, have the darker areas, the more social disadvantages. Okay? Serious crime, there were some issues. Delinquent crime, drug-related activity, and we generally found that they're more exposed than the general population to all of these social disadvantages. So just like anyone else, being exposed to these social disadvantages will impact your life in different ways. And that's what we're starting to try to look at right now. So I had to go kind of fast. I think I'm going to end here with the implications, okay? The implication to us is that we need to consider someone's environment when understanding mental health, recovery, and community inclusion. We can't just focus on them in isolation from their community, let alone isolation from family or friends. We need to understand people in their larger context. Just like any of us, we need to understand where we're at, what our resources are, what impacts our lives, how much crime is around, and all of that. And that we're also interested in understanding whether or not someone's subjective experience of their neighborhood. Do I feel like this is a safe neighborhood? Do I think that I have access to these resources? Whether or not that's related to someone's mental health outcomes and recovery outcomes and community participation outcomes. So 2 things, measure community participation and think about the environment. Think about where people live, resources, geography, all of those kinds of things. Our work suggests, at least in my opinion, I don't have the data to back it up yet, is about 50% of the reason why people aren't participating in the community and possibly mental health outcomes have to do with things outside of people. It's not the illness, okay? Stigma and discrimination, prejudice and discrimination is a key factor. That's an environmental barrier. Providers and family members saying, don't work, don't go to school, don't date, that's an environmental barrier, okay? Poverty and lack of access to resources, that's an environmental barrier. That has nothing to do directly with my having a mental illness, right? So we need to think about those things, and that's why I guess I would say advocacy is really critical too. So thanks for allowing me to walk around, and don't call me rock star presenter.
Well, I'd like to thank our speakers for a truly interesting discussion this morning. The notebook has disappeared here, so I'm going to wing it. Oh, here it is. Okay. Okay, I've got it here. One of the underlying themes of the conference has been ways in which we can bring communities together to address the issues of homelessness and recovery. We're going to now break into groups and get some dialogue going about things that are happening in our communities. This really will help us to put into practice some of what we've heard. Descriptions of each of the discussion groups can be found in your agenda. All of the sessions will be in the rooms located around the corner to your left as you exit the ballroom. In addition to discussion facilitators, we've also assigned a scribe to each session to take notes, which will be compiled and shared with attendees in the weeks following the conference. We hope that you will participate in the discussion and that the resulting dialogue plants the seeds of new ideas to take back to your communities to enrich and improve the lives of people living with mental illness and those needing a place to call home. Before I make my final comment here, which is really a logistical piece, I want to thank Dr. Salzer, Dr. Rogers, and Dr. Cook for a really interesting session. I know we promised you a Q&A at the end. We have run out of time and won't be able to do that. We're really pretty pressed. I'm looking at our presenters now. Will you have a few minutes to take some questions informally? All right, I appreciate that. So Dr. Cook, Dr. Rogers, and Dr. Salzer will be here in the front to take your questions. And one of the things, though, that we would ask, and it's a very important note, again today the Convention Center staff has a very short time to get this room ready for lunch and our closing session. So we ask that you please take everything with you when you leave and make your way out into the hallway quickly so they can set up. Lunch will be in this room and will begin at 11:45, and between now and then, you'll have an opportunity to plan next steps. So out the hallway, out the door to your left, and down the hallway. Thank you, everybody.